The next speaker for our symposium is Dr. Yi Lin. She is also the director of our CAR T program, and she will be talking about monoclonal antibodies and CAR T cell therapy in myeloma.
Good afternoon. All right, we'll start with the case. We have a 66-year-old gentleman who had newly diagnosed myeloma, and by cytogenetics features, presentation is intermediate risk. So he was started on RVD and has achieved a partial response. Then, as per standard care that you guys have heard in the last couple of days in the US, he went on to get autologous stem cell transplant and achieved a stringent CR after that, was continued on Velcade maintenance. About a year and a half later, he started to have recurrence with measurable M protein now and a new anemia. So this is not going to be a perfect real-world scenario, but if you were thinking about something that is a monoclonal antibody-based therapy to treat for him in the US, which one of these would be the top choice or the most appropriate choice? Would it be daratumumab as single agent, daratumumab with Lendex, Dara with Velcade-Dex, or Dara with Pom-Dex? Everybody likes B? C? B? All right. And that would be our preferred choice as well. It's almost like you guys have seen our MSMART guidelines. So here's a timeline for a monoclonal antibody that's been approved in the US. Not too long ago, November 2015, within a couple of weeks of each other, FDA has approved daratumumab as a single agent after 3 or more lines of therapy, or if the patient was already refractory to both proteasome inhibitor and IMiD. So if our patient was refractory to RVD, you could start to consider that earlier on, although that is certainly not a common practice for us to use monotherapy so early in the course. Elotuzumab Lendex was also approved for treatment after 1 to 3 prior lines. Then about a year later, we have Dara with either Lendex or Velcade-Dex, much earlier in therapy after just 1 prior line of therapy. June 2017,